Hello, good evening, friends. I'm Muralidhar, Dean, Sikkim Manipal Institute of Medical Sciences. At the outset, I would like to thank Dr. Tarini for inviting me to this conference, but unfortunately, due to my prior commitments, I could not attend in person. I asked Dr. Sunita Arora, shall I send the talk in video? She kindly agreed. So I'm sending my talk in video. I hope you enjoy the talk. My topic for the day is management of adolescent PCOS. Why adolescence is of special concern? PCOS affects approximately 11% of adolescents. Anything more than 10% is very significant. Prevalence of adolescents of hirsutism is 18%, and that's the biggest concern for young girl. Acne is another biggest point that a girl is always worried about. It is 35%. But it's oligomenorrhea, irregular cycles, that bothers up to 80% of adolescents. The adolescent PCO is a complex problem with endocrine, metabolic, and psychological features. There's a mixture of all the three in different proportions in different girls. Assessment and management of PCOS in adolescents is inconsistent with gaps in key evidence-based practice. That's why it deserves a special talk. Before I go to the management, let's look at the criteria. According to ISRE, ASRM, and Rotterdam, which is updated in 2018, it still maintains 2 out of 3 of the following: oligo or anovulation, PCO pattern on ultrasound, clinical and or biochemical hyperandrogenism. I have some reservations for this because if you choose these two, they're almost same. The oligoanovulation is the cause of PCO pattern, but you are leaving out a major issue, that is clinical or biochemical evidence of hyperandrogenism. So I would rather go with the definition of androgen excess and PCOS Society, which was given way back in 2006. That is, hyperandrogenism is mandatory for diagnosis. Even after the 2018 PCOS guidelines, there were a lot of meetings and discussions. In June 2019, it was felt what I felt. Rotterdam criteria increased the prevalence as much as 50% due to diagnostic switch from androgen excess to ovarian morphology. If you do ultrasound in any girl, there will be some amount of ovaries because they are all primordial follicles and they have irregular cycles. There is no ovulation happening. So morphological threshold was raised from 12 to 20 follicles in each ovary. It also went ahead to say ultrasound is not necessary in subjects with hyperandrogenism and ovulatory dysfunction. In adolescents, both oligoanovulation and hyperandrogenism are required. This is a main observation that was done, which I have been telling all along. Hyperandrogenism is a must because oligoanovulation is not uncommon in adolescents. Ultrasound is not recommended for diagnosis. Look at that. That's what is very, very important, because if you just do an ultrasound, as I said earlier, all ovaries look PCO ovaries in adolescents. So explore the potential of AMH levels to guide the diagnosis is another suggestion. Do we need additional criteria? The proposed additional criteria are BMI. Yes, of course, BMI is very important because 2/3 of the PCOS patients can be obese, but not all. Insulin resistance done in different ways was also proposed, but my take is obesity is not essential for diagnosis, as I said earlier, as there are lean PCOS also. Although obesity does worsen the clinical scenario. Universal screening for insulin resistance is not required. Then whom should we do this screening on? The indications for testing insulin resistance are obesity, premature adrenarche, irregular cycles for more than 2 years post-menarche, and androgen levels more than 150 nanograms per DL. They are the ones who require testing for insulin resistance, and the best test is 75 grams OGTT, which is also called WHO GTT. The recent thoughts about the testing for insulin resistance: yes, you can do OGTT in all high-risk patients, but if you don't want to do that full-fledged OGTT, you can also go for FBS or HbA1c in any patient at any time to know the glycemic status. OGTT is usually advised before conception, but of course, today we are discussing adolescents. Which androgen to be estimated to know the biochemical evidence of hyperandrogenism? This is a big debate. The androgens are ovarian, can be from ovary, that is androstenedione, testosterone. It can also be from adrenal glands, that is androstenedione and dehydroepiandrosterone sulfate, DHEAS. Now, all androgens can produce PCO morphologies. That's why if we estimate any one of them should be okay. But the problem is that we should have a proper laboratory that we can rely upon. Which testosterone? A calculated free testosterone or free androgen index or calculated bioavailable testosterone. There are different ways of estimating them. So today I'm not going into the details of that. Androstenedione and dihydroepiandrosterone sulfate, that is DHEAS, could be considered if total or free testosterone are not elevated. However, these provide limited additional information in the diagnosis of PCOS. A clinical evidence of hyperandrogenism should be good enough. Don't worry that you don't have a proper lab to estimate all these kinds of testosterone. Should we estimate gonadotrophies? Because when I was undergraduate and postgraduate, it used to be like FSH-LH ratio is altered in case of PCOS. Let us look at that. PCO can be eugonadotrophic. That is very, very important to understand. So there is no question of LH being raised here. PCO with regular cycles have hyperandrogenism with normal LH. That is another important observation. LH levels have no relationship with insulin levels. And finally, higher LH is more evident in lean PCO rather than obese PCO and is the cause of hyperandrogenism in them. So what is my take? Estimation of FSH and LH is not mandatory to diagnose PCOS. Hyperandrogenism, clinical or biochemical, is good enough. Testosterone is definitely required. Do we need other tests? Yes, of course, TSH is the commonest cause of anovulation that has to be ruled out before you brand a person as PCO. Prolactin, hyperprolactinemia, is another cause of anovulation, and 3% of women have hyperandrogenism because of that. AMH is a big marker of disruption of follicular genesis, so it's worthwhile testing that as well. But it is higher in those with amenorrhea rather than oligomenorrhea. Inversely proportional to benefit with weight loss. What is my take on this? All three, that is TSH, prolactin, AMH, guide in the management, hence may be performed. AMH is not yet alternative to PCOM. Clinical evidence of hyperandrogenism, as I have been telling, is equally important and sometimes easy enough. So what are they? Acne, hirsutism, and alopecia. In adolescents, severe acne and hirsutism are enough to diagnose because alopecia makes some time to occur. Standardized visual scales are preferred. We have Ferryman-Galway score for hirsutism. Levels anything more than 6 to 4 indicate hirsutism. For alopecia, Ludwig visual score is preferred for assessing degree and disruption of alopecia. There can be ethnic variations. This has to be kept in mind. Caucasians have mild phenotype and higher BMI, whereas Africans have higher BMI and metabolic features. Middle Eastern and Hispanics have more severe hirsutism, whereas Southeast Asians and Asians increased central adiposity, insulin resistance, metabolic risk, and acanthosis nigricans. Each stations have lower BMI and milder hirsutism. What else causes hyperandrogenism is to be understood before we brand that it's just because of PCOS. Otherwise, it can be severe consequences. Non-classical congenital adrenal hyperplasia, the criteria is 17 OHP is more than 800 nanograms per ml. Androgen tumors, one should not miss them. Otherwise, it can be a detrimental thing for the girl. Here, the testosterone is more than 150 nanograms per dl. Severe insulin resistance syndrome, the abnormal 2-hour OGTT is the evidence of that. Cushing's, cortisol less than 1.8 microgram per dl, and idiopathic hirsutism, normal serum androgens. That's how you differentiate from PCO. Now, one word of caution. Many people confuse hypertrichosis, that is hair on the hand and on the legs, as hirsutism. Hirsutism means hair in the men distribution, that is over the lips, on the chin, and on the chest. The other dilemmas are puberty may mimic PCOS as per Rotterdam criteria. This I have been telling again and again. 50 to 60% have polycystic pattern because of irregularity or immaturity of the HPO axis in that age group. Irregular cycles usually happen for sometimes 2 to 3, sometimes even 4 to 5 years after menarche. Similarly, in postmenopausal transition period of androgen excess is seen. That's why there will be irregular cycles as well. So one has to exercise caution in branding adolescents and elderly women as PCO. What are the recent thoughts about ultrasound? Ultrasound should not be used for diagnosis up to 8 years after menarche. Look at that. Due to high incidence of multifollicular ovaries in this life stage, TVS is better if at all, but the challenge is, can you do TVS in adolescents? If they are sexually active, yes, you can do. Threshold follicle number should be more than 20 in either of the ovaries and or the size of either ovary should be more than 10 ml. Now, some people say both ovaries, some people say either of the ovaries. I think better to say both ovaries having 20 follicles each and both ovaries measuring more than 10 ml. Now I come to the lecture proper, that is management. The management is always concern-centered. There are 3 main concerns in adolescence. One is because of anovulation, which causes menstrual irregularity, fibroids, endometriosis, infertility, and endometrial carcinoma or ovarian carcinoma. But in this, the last 2 are not really the concerns of adolescents. Androgen excess can cause hirsutism, scalp hair loss, acne, depression, whereas metabolic dysfunction, which is underneath the PCOS people, it can cause obesity, sleep apnea, NASH, hyperlipidemia, type 2 diabetes, and cardiovascular events. As I said earlier, these are the main concerns due to anovulation in adolescents, and all of them due to androgen excess, and mainly obesity, sleep apnea because of metabolic dysfunction. So the goals of treatment are accordingly: management of irregular cycles is number 1. Amelioration of hyperandrogenic features is number 2. Both of them are main concerns of adolescents. Then ovulation induction for those pursuing pregnancy, that is after adolescence when they get married, they would have infertility. And contraception for those not pursuing pregnancy even after marriage. And management of underlying metabolic abnormalities, not a big concern in adolescents, but yes, some of them may have. Prevention of endometrial hyperplasia and carcinoma, just an education is good enough, but we don't have to worry much about them. So as I said, the first 2 are mainly seen in adolescent and young age. The next 2 are in reproductive age, and the last 2 are elderly or later age. So let me talk about management of irregular cycles. Now, this is a big concern. More than the girl, the mothers are worried if she doesn't have regular cycles. Yes, of course, it's a worry, but one must educate mothers as well as the girl that there is no need to have 12 cycles in a year. At the same time, there should be some menses or withdrawal every 3 months. Otherwise, there will be unopposed action of the estrogen on the endometrium, and that can cause problems later on in the life. So to this end, if her BMI is less, and if the person is particular to have 12 cycles in a year, then you can prescribe COC pills. Low dose also is acceptable. BMI more than 30, and if the girl is convinced that she can have once in 3 months, or she need not have nearly 5 years of menses, nothing will happen. Bad blood is not going to be collected in the body. Then you can go ahead and prescribe progesterone withdrawal once in 2 to 3 months. Or if the girl can be convinced, because abroad the LNG IUS is used even in the unmarried girls as a method of contraception because they are very sexually active even in adolescent age. But here, if they are reluctant, you don't have to press on that. But if they are willing, you can put LNG IUS where they will not have periods for nearly 5 years. And whenever she gets married, it can be removed. And as you know, fertility is restored after that. But anyway, it is very difficult to convince people to have LNG-IUS in India, probably. The recent thoughts about OC pills, the 35 mcg ethinyl estradiol plus cyproten acetate preparation should not be considered as the first line. However, they can be given. They have been very popular in India. But what Ishray says is that should not be the first line in PCOS as per general population guidelines due to adverse effects, including venous thromboembolic risk due to cyproterone acetate. Various COCP preparations have similar efficacy in treating hirsutism, so go ahead with whatever is your choice of COCP. COCP with metformin may be most beneficial in high metabolic risk groups, including those with diabetic risk factors, impaired glucose tolerance, or high-risk ethnic groups. Now I come to the second goal of treatment, that is amelioration of hyperandrogenic features. Now, the role of pharmacology here or pharmacotherapy is very little, whether it is acne or hirsutism. Of course, for acne, nowadays the dermatologists take good care of them, even for hirsutism. The mechanical removal is the best method for already grown hair. It can be waxing, threading, epilation, but men have understood it better that shaving is the best method. But it is not appealing to any girls. Rather, you can go for electrolysis or laser removal of the hair. Pharmacological therapy, you can use COC containing, that is cyproten acetate pills, but of course not as a first line. But the problem with this, whether it is anti-androgens like flutamide, spironolactone, in fact, I did a study on flutamide. I gave it as a thesis to one of my students. They come back with vengeance. The hair comes back with vengeance the moment you stop this therapy. That's why I said at the best, pharmacotherapy can soften the hair. They will delay the regrowth of hair, but the best is laser removal of the hair. So metformin reduces androgens, but not the first line of drug as far as hirsutism is concerned. The next popular treatment is drilling of the follicular cysts or the ovarian cysts in PCO. So I will have two slides about this. It acts by reducing intrafollicular androgen milieu. It has a limited role up to 6 months only. There is an improvement in ovulation, but not the cumulative pregnancy rate in case of infertilities. No role in insulin resistance, not for unmarried girls at all. I've seen many gynecologists, doing this for young girls, which is wrong. They will land up with adhesions and infertility later in life. Not the first choice, even in married. So what are the guidelines? Not more than 4 punctures, not more than 4 millimeter depth, using lower electrical energy, and cooling the ovaries with irrigation if monopolar is used. Not more than 4 months gap after procedure if you want to induce ovulation in infertile patients. And it reduces ovarian reserve, that should be kept in mind. So my take is avoid drilling if possible, but if at all you have to do, use it as a last resort, temporary resort for ovulation induction only, not in young girls or adolescents. Now I straight away I skip the induction of ovulation and contraception part because that is not concerning the adolescents. The management of underlying metabolic abnormalities is a concern. We have to spend a lot of time with these young girls to change their lifestyle. Both overall calorie reduction and composition of diet is very important with intermittent fasting, which is the latest fashion. 2 to 5% weight loss improves metabolism. Metformin should not be used as a means to lose weight. Only if there's insulin resistance, it can be used, because metformin really does not reduce the weight. It will reduce your appetite because of the GI, side effects. But after 6 months, one gets used to the GI side effects, then they'll start eating as before. All three types of exercises, that is stretching, aerobic, and the weight bearing exercises, should be done 3 times a week. So low carb diet, the truth is that 12-week study involving 28 obese women, they used all sorts of diet, but all are same. I have made my own formula, that is Murali's 5C formula, convince them first that it is necessary to reduce weight, and ask for conviction to strictly follow what it takes. Control diet, 80% responsible for the weight loss or weight gain. Intermittent fasting is the best. Exercise also is prescribed, but it helps only in 20%. Consistency is very important. Make it lifelong habit. Don't go for crash courses. It will crash. Compliment them whenever they lose even 5% or 10% so that they get encouraged. Well, it is easier to tell. I myself, I'm finding it difficult to follow all these things, but we have to somehow convince ourselves first and then others. Depression and anxiety, as I said, is the main concern in youngsters, especially if they have hirsutism and acne. So adolescents with PCOS have impaired quality of life and higher rates of depression and anxiety compared to those who are similar BMI without PCOS. So efficacy and safety of antidepressant therapy has not yet been established in women with PCOS. It is better to take, the advice of the psychiatrist before we use them. Finally, I come to prevention of endometrial hyperplasia and carcinoma. So we have to teach them that it is due to unopposed estrogenic action. So as I said earlier, the first line is COC pills. If the girl doesn't want to take the pills every day, then you can actually go for, once in 3 months. These are the benefits of COC pills. So if he is not willing to take, the second line therapy is cyclical progesterone only therapy, that is withdrawal once in 2 to 3 months. As I said earlier, LNG IUS also can be inserted. Metformin, of course, particularly in women with contraindications to COC use, but it has not been proven to be endometrial protective. Metformin restores ovulatory menses in 50% of PCOS. What about endometrial sampling? Well, it is not indicated in adolescents, and it is not sometimes feasible as well. Cumulative estrogen exposure is more important than absolute age in causation of endometrial hyperplasia and carcinoma. So it is hardly seen or never seen in youngsters. However, when they become adults and later elderly, we have to advise endometrial sampling if the endometrium is thick. So sum and substance of what I said so far is PCOS is a hyperandrogenic state, especially of ovarian origin. So a clinical or biochemical evidence of that is very important to diagnose. Clinical evidence can also be the obesity and other problems, whereas biochemically you can prove it by even insulin resistance by doing a GTT in obese women. Treatment is based on symptoms and need of the patient. OC pills, combined OC pills and progesterone withdrawals can be used for menstrual irregularities, and mechanical methods to get rid of established hair. Pharmacological agents only delay the regrowth of the hair. Weight loss is very, very important, should be achieved through lifestyle and exercise both. Ovarian drilling should not be done in adolescents. If at all, it is done in infertile patients if there is a clomiphene resistance as a last resort and a temporary resort. Thank you very much for your patient listening.